Okay, good morning, everybody. And I want to introduce Dr. Ron Kruger. He's my co-chairperson, and we shall be presiding this session with Rohit Sethi, who is coming probably in a few minutes from now. And we have a very active and very interesting session dealing with the topic, looking for a solution to presbyopia. What options do we have today? We have a very active session in which we have many speakers, a total of 10. We have quite a strict control on the timing because we want to offer to you an overview about everything that is today evidence-based, useful for presbyopia correction. So welcome to the session, and the first presentation will be by Nadine Sethi, Why I Prefer Refractive EDOF, Extensive Depth of Field Lenses. Thank you. You introduce the second, right? Sure. Family fine? Family, good.
Is it on?
Nadine, you can proceed. Thank you.
Yeah. Good morning, everyone. I'd like to thank APO and AIOS for giving me this opportunity. So my topic today is why I prefer refractive EDOF. Now, we are in the generation where no more 20/20 or 6x6 vision is not enough. Patient wants more. And the problem is, the more options you put into the lens, you're having some kind of a compromise. Now, for instance, let's say if you want the best quality vision, monofocal is the best, but you have very less presbyopic correction. But if you want 100%, at least maximum presbyopic correction, like a multifocal or a trifocal IOL, but you have a compromise in quality of vision. So this is where the refractive EDOFs come into picture, where it has a perfect balance between presbyopic correction and visual quality. Now, the main thing what happens here is there is no splitting of light. That is how it's able to maintain quality of vision. And the new generation refractive EDOFs, actually, the halo profile is almost similar to a monofocal level, including the dysphotopsia. As you can see here, hardly you can, if you look at the profile, all the three dots on the right, you hardly can make out difference which is the refractive EDOF. That is the quality of vision it's trying to deliver. Even if you look at the visual symptom questionnaires given to patients, it's very similar to that of a monofocal IOL. Now, the other thing, what happens in a diffractive IOL, there are certain criteria what we have to look at, right? But in a refractive IOL, because it behaves like a dysphotopsia profile is like a monofocal, so the workup is just like any other monofocal, and you don't need to invest in very high-end machines to look at it. So if a person specifically is not using presbyopic IOL currently in their practice, this is the best lens to start off with, because this is a very forgiving lens, and and the best part is you hitting a 20/20 vision is more likely with a refractive EDOF than a monofocal. That is because it has a little landing zone from plus 0.5 to minus 0.5. So anywhere you have a post-refractive error landing anywhere in between this, you will have a 20/20 vision. That is why this is the best lens to start off with. And definitely, as you know, that neuroadaptation also is much quicker in a refractive EDOF patients. Now, the main point about these patients is a lot of times, before refractive EDOFs came into the picture, a lot of eyes with hyoid aberrations or some other eye issues, we used to exclude them for any presbyopic lenses. But now it has completely opened a new set of patients who are suitable for a presbyopic correction, even though they are not non-pristine eyes. So as you can see here, even in mild maculopathy, glaucoma, amblyopia, all these kind of conditions, 90% of the patients were satisfied with the vision, and there was a significant improvement in vision too. Now here you can see in glaucoma patients where it was implanted, and you can see the contrast sensitivity did not decrease in EDOFs, and also postoperative visual field remains stable too. Here's a set of patients which was operated in radial keratotomy with refractive EDOFs, and then 79% of the patients had better than 20/40, and 62.5% achieved the target refraction, and so on and so forth. Now here, you can see it's been implanted in an age-related macular degeneration. And again, the patient, the eyes with early ARMD maintained normal contrast sensitivity and had good vision. But when you combine this with the micromonovision, it works really, really good. So when you target a micromonovision of 0.5 or 0.75, that's when the patient bilaterally almost has 20/20 vision at all distances. To summarize, basically, night driving refractive EDOFs are really good. Neuroadaptation is much quicker as compared to a multifocal. Dysphotopsia is very minimal, very similar to that of a monofocal. The range is more smooth, not like step-like a trifocal. And patient happiness also, usually patients are much happier with this particular lens. But the issue is that whenever we think of a presbyopic IOL, we have so many options in the market, and we really don't know. Forget about explaining to the patients, we ourselves find it difficult to understand. So what I do is I make it very simple. I categorize into diffractive and a non-diffractive. So even future lenses also, you can just put into any of these two criteria. But again, how do I decide whether I have to implant a diffractive or a non-diffractive IOL? So this is my decision tree. If a patient wants presbyopic option, first I see if the patient is suitable for a diffractive IOL. So this is my decision. If at all it's suitable for all these categories, then if the patient is normal or not a type A personality, then I simply go with a diffractive IOL. But if the patient is a type A personality, and then you can simply push over to a refractive EDOF or a non-diffractive IOL. And if the patient is not suitable for a diffractive IOL, then either if it is only high order aberrations, you can either regularize the eye and then push to a diffractive, or you can simply go with a non-diffractive IOL. I think this is a simple decision tree which not only makes it simple for the doctor, it makes it so much more easier for the patient to decide. Even a workflow also will become so much more easier. Thank you so much for your time.
Okay, thank you. Our next speaker is going to be Vaishali Vasavada, who will talk a little bit about why I prefer a diffractive trifocal.
A very good morning to all, and thank you for the opportunity. And I'll try to make it in time. Dr. Shetty has really made my point much easier. Why I prefer diffractive trifocals. I do receive occasional research grant from Alcon Laboratories. I think the basic point we need to understand is that the newer generation trifocals have an excellent range of vision continuity, as well as they provide best-in-line spectacle independence, and the whole discussion about dysphotopsia and the negative effects is really going down drastically. So the chair time I find in my practice, and I'm sure a lot of you echo this, is going so much down. And the number of patients whom I can implant a trifocal are increasing. And this is what a recent meta-analysis also says, that 9 out of 10 patients do not need spectacles, and yet only 3 and 5% patients had any significant halos, glare, or starburst. So I think that's the real advantage we have with the newer diffractive trifocals across platforms, I would say. Let's look at real-life scenarios rather than going into a theory. This is a 71-year-old lady who wants to do almost everything like you and me would want to do, and I hate wearing these glasses just like she does. So she has come for a regular cataract surgery and has astigmatism. So we go ahead with a diffractive trifocal, and she has excellent continuity of vision and doesn't need computer for almost any activity, including driving. So this was a very standard scenario where we see that trifocals are of course a great option for spectacle freedom across distances. But let's move on to this really coveted situation of an active surgeon ophthalmologist who uses progressive glasses and has only about 10% use of multifocals in his own practice. But from whatever experience he has and he listens to his patients, he feels confident that I want to go ahead with a multifocal, a trifocal. And he also drives in the city at night apart from operating. So we were really on the back foot at this occasion, and we were trying to talk about all the negatives, all the flaws. But he feels very confident, and finally, having done his complete evaluation, of course, we did an astigmatism correction inbuilt as well. And after this trifocal toric binocularly, he is able to operate, he's able to drive, and in fact, he says that he would recommend it to any other surgeon. He does observe some halos at night, but as you see here, he says they are not really very bothersome. So it is now true that trifocals are also a great option for people who have a very precision-oriented and an active lifestyle also. Of course, it involves a discussion one-on-one about the pros and cons, but I think that category, the exclusion is becoming so much less now. Of course, the basic three things if I have to name, or four things. One is to evaluate the ocular surface and treat if necessary, because these aberrations, as you can see here, are a source of not only poor vision quality surface symptoms, but the first refracting surface of the eye is the tear film. So we better treat those because these will mar the results. The second, as we all understand, is to ensure a negligible residual refraction, both spherical as well as astigmatism. And so the use of modern devices, diagnostics, formulae, and like I said, astigmatism we cannot overemphasize. Looking at not only the magnitude but the regularity of Myers. So actually look at the raw data that is being pulled out from your machines. Just don't look at the printout of what it says. And having a good regular astigmatism, even if it is to the tune of 0.75 degree diopters, is treatable very predictably and really enhances results. And this is one paper we published way back in 2018 where that's when we started performing a posterior segment macular OCT for all our cataract patients before we counsel them for any IOL, leave alone a presbyopia correcting IOL. Now again, let's move on to other scenarios which are a little more diverse. Here is a 73-year-old myope, so always used to good near vision. Somebody did a monofocal IOL for her 3 years back, and she's not happy because she was never given the option of a multifocal lens at the time. So now she has come to us, can we do something? And this is data from her chart. This is the pseudophakic eye, as you can see. She has a spherical, cylindrical, and a presbyopic refractive error. And we are looking at this right eye now for refraction, for cataract surgery. So we again discussed with her that because it is going to be a trifocal only in one eye, we cannot promise that you will be rid of the glasses, but we can reduce your dependence drastically. And she really agreed, and she understood that she didn't want to compare the distance vision in both eyes. We told her two things. One, you might need a little pair of glasses. Second, please don't do this, especially comparing your distance vision in the monofocal and the trifocal eye. Now, post-operatively, she is 6/6 partial or 20/20 partial. Binocular is 6/9, and she's doing very well for near N6 partial. So I think it is also a good idea for unilateral or other eye monofocals. And the main point I wanted to bring about is patient needs to know all their options before you decide for them whether it's EDOF or this or that. Tell them, discuss with them. What happened to my, can I have my slides on the? Yeah, so this is one case which is really, I think, the icing on the cake. A 42-year-old lawyer, criminal court lawyer, has had a familial nystagmus, comes with subcapsular cataracts. He understands his problems, what he has since birth, but he cannot wear glasses. And this is his, again, data post-operatively following bilateral toric trifocal implantation. 6/9, so 20/30, not 20/20, that's okay, he doesn't have that potential. But N/6 and all unaided, plano. So this is the video I wanted to show. I hope it plays here. Can you play the video for me? It was playing on your trial. I'm so sorry. So this is an eye with nystagmus and trifocal IOL, and here I want to show you that it's not just saying that I do this, I do that. This is the contrast sensitivity curve, which is just marginally at the lower level for his age matched. And this is also with glare. You see that dotted line on your right screen is with glare. So I think, and can you have the volume up, please? So I'm making him read the fine print of the Hindi newspaper, which is a really low contrast, and you see there are no lenses in his trial frame. And this is, of course, with his consent. So I think the whole message I wanted to drive, there are issues with any lens, including a trifocal, and the main issues we talk about today are two things, comorbidities and visual disturbances, and in country like ours, I think cost. But in most cases, with a good team that supports you, what is my strategy? Probably the emphasis is more on not to include or whom to exclude. It used to be a lot of discussion on who is a good patient. I think now the discussion is who is that little segment who is not a good patient for a trifocal. And the top reason for me, I think finances apart, is a hesitant surgeon or an uninformed patient. Thank you.
Thank you very much. Very nice presentation, Dr. Basavada. Now it's my honor to introduce you to David Chang. He will talk about why choose just one. I prefer Mix and Max. Thank you, David.
All right. You just heard a really good debate, and I'm going to tell you why they're both right. So I see my slides here, but I don't see them on the screen. Yep, all right. So I am a consultant for these companies. You know, I don't really like arguments, so I'm going to tell you why I use both. You know, both speakers alluded to having too many choices, and it can be like this dilemma for my granddaughter, what do you choose? And we won't go through the list of things that an informed patient really wants to know about. And Dr. Shetty mentioned this book that Rich Tipperman showed to me called The Paradox of Choice, in which the authors cite a lot of social experiments. And what you find is if you give people too many choices, it creates a lot of indecision and anxiety because there's the fear that I'm choosing something and I'm missing out on what I'm not getting, the so-called FOMO. And so this is why I think it is important to help people by making a good recommendation. They also, both speakers also talked about our dilemma. We have to be very efficient and yet very effective at helping people reach a choice with a very confusing value proposition with all these optical terms. And so this creates a lot of anxiety for people. Not only do they have to choose which lens, but which distance is most important, and we get frustrated with the amount of time this takes and indecision. You've heard different approaches. I break it down by similarly to Dr. Shetty saying, well, you're either going to get a single focus, an extended focus, or a multiple focus lens. There's basically three choices. And I try to avoid monofocal because it gets confusing with monovision in English. If you have astigmatism, well, a toric feature can be added to each of them. Now, I think we'd probably have an easy decision if we had a lens that gave binocular distance intermediate. Patients had no problem driving at night, and yet they had that near convenience, cell phone, watch, makeup, price tags. But if this lens existed, we wouldn't have needed the debate this morning. It doesn't. But what you can do is blend the two. So if we're talking about avidity, for example, I explained that the strong side, especially in California where all of my patients drive at night, you have excellent night driving, but you're going to need reading glasses, very likely to see your text messages. That won't be necessary with the Panoptics, but there's that risk of rings. And even though most people adapt, I have a little concern, as does the patient, about whether they'll be the exception. And don't forget that they're talking to friends, looking on the internet, and it only takes one person complaining about the rings at night to scare them off. So from the start, telling them you're going to get one of each, they're not having to choose. They're going to get that binocular distance intermediate, have no problem driving at night, and still be able to see their cell phone. And this immediately makes them happy. In the United States, a popular choice on the menu is a combination of the lobster and the filet mignon. That's called surf and turf. And I talk to my patients that this is like surf and turf. They're getting the best of both worlds, so the patient doesn't feel like they're having to give up something by not choosing the other. And of course, I explain we're going to start with one eye at a time. You're really going to test drive that lens. So if they're already myopic, I know they're used to near, or they hate glasses, we'll start with the Panoptics first. I'll put it in the non-dominant eye, whether it's the worst cataract or not. If their main complaint is they're having trouble driving at night, I know I have to put the Vivity at least in the dominant eye. And then maybe, maybe 1 out of 5 times, 1 out of 4 times, the patient says, I like this lens so much, I want the same lens. Well, that's easy. but you've already set it up that they're going to solve whatever they don't like about that lens by using the other choice in the other eye. And, you know, although we can do mini monovision, as our first speaker said, you know, I say this is actually no adaptation because you're going to have the same vision at distance and intermediate. And this is really important. You know, if you're going to have only one eye for distance, you have to make it 20/20. And yet, sometimes they're 20/25 minus 20/30 residual cylinder sphere. So boy, when you have the second eye at distance, that really helps because you, again, 1 + 1 = 3, and you get that recruitment. Now, there's another choice with J&J. We don't have the Pure C yet in the United States. I think there's a little merit to using the same platform. You're really putting in the same material, same index of refraction, same chromophore, same edge design, and the same A constant. And so I think this has really made a difference, not just happy patients, but getting them to make that decision and eventually ending up 20 happy. Thank you very much.
Okay, great debate so far. Next, we're going to do a live simulation where I'm going to be the subject, but before we do that, we're going to invite Helena Filippi to come up and to sort of set the stage for that.
Mr. Chairman, thank you so much for the opportunity. So, I seem not to be passing the slides. Cannot run. So we have the first slide already. And we have seen, have heard from the previous presentations, a very good set of the stage of the opportunities, of the possibilities that we have in the clinic to address presbyopia, and also the challenges of explaining exactly what is to be expected by using one or another, or mixing them as well. And so this presentation would be to share some technology and a technique as well that can make the patient really experience what is about choosing one or another, or mixing both, and have this immersive experience using being as if already has been operated on. So I hope this. Okay, so despite technically perfect surgery, how many of us have had patients dissatisfied with their IOL choice, even with the best explanations? And we have already heard about the differences that the many possibilities that are on the market in IOLs can offer. They are all different, certainly much better than a cataractous lens can offer, and also a little bit lower than a 25-year-old healthy eye, but much closer to that. And these differences can be the exactly key for a satisfied or an unsatisfied patient. So unmet patient expectations are usually concerning dysphotopsias, depth of focus, contrast sensitivity, and vision in different lighting conditions. And these are very difficult to explain. When we think about choosing the best patient, we always know that that selection is a mismatch as well of our personality and our choices and the person that we have in front of us, the patient himself. So how can we choose? And our proposition is to introduce live simulation to replicate what happens as if the IOL was already in place before surgery. It relies on technology that is supported by adaptive optics, mimics post-operative optics in real time, virtual reality simulations, and can provide this immersive experience to the patient as if he or she is already using the IOLs, and also wavefront guided imaging as a technique. We will see in a minute. The person looks through a simulator and have this experience near, intermediate, and distance vision, and also can test different IOL types, as we have heard before, and have the experience and the sensation as if were already operated on, and make a better choice with her or his doctor. So there's evidence sustaining that this technology provides reliable information regarding what will happen, to anticipate what will be the sensation, the feeling of the patient with the new IOL. And also, there's also experience as well at the clinical practice. For instance, this is a case of a 50-year-old patient considering a trifocal, and after simulation and the difficulty adapting to halo effect, a need-off lens was chosen, and the outcome was fully satisfied with no post-op regrets. There are already also other applications of this technology, of this immersive experience, not only for IOLs, but also for contact lens, laser presbyopic surgery, fine-tuning the right binocular combination. So a whole world of reality, new reality, can be devised and built for the patient to experience before. So in summary, live simulation for better overall surgical outcomes will enhance patient education and shared decision-making, and not only this, but also reducing the time that is needed for explanations, enables personalized IOL selection based on the lifestyle and the personality of the patient, and also will lead to fewer post-op complaints and regrets in IOLs exchanges. And virtual reality and adaptive optics and artificial intelligence-driven IOL simulations will most probably become standard and be used in the future. So we have now a live demonstration of the technology. So we have already Professor Kruger experiencing the simulator. And we have to wait a little bit, so this can be done at the office during a consultation. And besides explaining and having images and having booklets for the patient and having the time that all patients deserve when explaining everything and emphasizing the choice for the IOLs, we can see that our time is already very well taken for this experience, because the patient can live in a kind of a second life virtual reality of an immersive experience. So it has to be adjusted for the refraction of the person, and then we can try an head-off and ask Professor Kruger, what is the experience?
Sure. So just to start, I have not had any cataract surgery. I'm a slight hyperope. I am wearing a contact lens that allows me to use monovision. So I've been used to monovision in the past. And right now I have a simulation that's giving me distance in both eyes with an EDOF, a Vivity. And I can see the distance pretty well with no real distortions. And I can read pretty nicely all the way down. So I think I've got decent range with this.
So
Okay.
the near and far, comfortable.
Okay.
Okay, let's try another option. And this would be a mix and match.
Okay, mix and match. So I
Near
can
and far.
see the distance pretty well. Maybe it's not quite where it was before.
With the head off. And now the near vision.
the near vision is also pretty good. But I don't think it's superior to what I had when I was just wearing the EDOF. So maybe I'm one of those people who just needs a little bit of extra range of near without having the full range.
Okay, so before this, we can see that this experience will help us a lot, and especially will help the patient a lot in terms of selecting and take a shared decision of what would be the best choice for the patient.
So maybe we'll try to see if a bilateral trifocal, what it looks like for me.
Okay, let's try a trifocal.
1 minute to go.
One minute to
minute
make
to
it
go.
happen. Okay, so this is trifocal.
So magic.
So I noticed that the distance doesn't seem as robust and clear with the trifocal. And I can see pretty well up close, but I don't think it's worth it for what my distance was when I was using the EDOF. So I think my vote would be EDOF.
EDOF. Thank you so much, Professor Kruger. Thank you so much for your attention. Thank you.
Okay, thank you very much indeed, and very interesting. And now we have time for discussion in a very interesting topic, and I would like to have the first Dr. Sethi, who is there, right? And, I would like to point out something about the personality. Personality problems, I have not the same opinion as you, because for me, type A personality is not a contraindication. It's a good indication. The problem is negative personality. Negative personalities, whatever you do, will give trouble. And if we would have a test in the office, to detect negative personalities, we would avoid most of the bad patients, Just the 20/20 A1 failures will not happen. But type A is not a bad indication as far as the patient has not a negative personality. What do you think?
So basically, sir, these are the patients which normally I say is that we start off our conversation with saying that, okay, look, if you choose a trifocal or a diffractive, you will see a little bit of glare and halos, but it won't be that disturbing. And you would have spoken to the patient for almost half an hour. At the end, again, the patient starts asking, are you sure I won't have glare and halos? These are the patients you say, okay, I think it's better to keep it simple. Let's go with a EDOF where it has very low glare and halos, and then they do well. But any patients who are unaccepting, have a little bit of OCD of being very particular about the smallest detail, and they keep saying, I don't want to see glare and halos, they're the ones I think better to avoid. Absolutely.
Yeah, thank you. Thank you very much. Any question, Dr. Sethi, about EDOF? No? Now is the time for trifocals. Trifocal lenses are by Dr. Basavada. And it's clear that the trifocal lenses are much more demanding in terms of patient selection. And here is when negative personalities arise, And so in my opinion, if I have a perfect patient in terms of no abnormal cornea, no surface, not particularly negative personality, is my choice. Why? Because the patients see better. And in Spain, at least, my patients want to read for near without glasses. What do you think?
I think I totally agree that even with the best of explanation, you told them that the EDOF will give you everything, but when somebody who never wore reading glasses, next day they have to read even for a fine print, they are never very happy. So I agree with you that if everything is okay, and if they are not particularly they don't come across as a very negative person, I would offer them a trifocal.
So my question now is, which is the percentage of the patients in which you use premium lenses, in which you use trifocals and EDOF conversion?
So if we count presbyopia correcting lenses, I think more than 50% of my practice, because I'm in a private practice, is one of the two. And of this, I would say the ratio would be, it used to be more trifocals, but now I think it's about 75% trifocals and 25% EDOFs, roughly.
So majority of patients are for trifocal in Europe.
Yes, if they're wanting spectacle independence, I think that is what I would give them as a first option.
Okay, see Dr. Ang, who has a great experience. Which is the proportion of your cases with EDOF and with trifocals? Quickly, fast.
The EDOF has eaten up a lot of the trifocals, so maybe 60-40. Closer to 50-50. Yeah, because of the driving, the people who drive, really, I put them on EDOF. So
Okay.
60% trifocal.
And Ronald, what about you?
I would say more heavily weighted toward EDOF. And, I also do light adjustable lenses, which gives it an ability to titrate it and give some spherical aberrations. So that works well, but it's not something readily available outside the United States right now. I do have one quick comment. I wonder sometimes if the lifestyle in different parts of the world have a factor, because in Europe, there may be more people that use trains and transportation that way. In the US, there's a lot of people driving. They're driving at night. They don't like halos and glare. I have one colleague friend of mine who was a marketing person for one of the big IOL companies who actually had his cataract surgery done, had a trifocal placed, and then told me in confidence, you know, I look off and I see these lights and all I see is rings all over the place. And he was a little despondent about that, even though this was the lens he was selling. So I think maybe neural adaptation helps over time, but it is a little bit disturbing when they first see that. And I always kind of wonder, is that compromise worth it?
Yeah, you know, I don't think that lifestyle is that different in different parts of the world. Asians traditionally are expected to read more. I don't think that they read more than Europeans and Americans. When they are educated, they read as much as we do. I think that the style of life is similar. Probably the tolerance to problems is less important. You know, probably in Europe we are more tolerant, but I don't think that there is a clear sociological difference. The main difference is the brain. The main difference is the adaptation. And this is why I want to stress different factors. Number one, most of the lenses that you have in the States, not all, but most of them have a low AB number. Low AB number, what does it mean? Less transmission of light. And with less transmission of light, you have more halos simply because you have less light in the retina. Those lenses with high AB factor, trifocals, do better than those that have low AB factor, non-trifocals. And this is one of the many details that you have to think about when to choose or not a trifocal lens. And indeed, this is something that probably the simulator that we shall discuss now.
Yeah, and I know, before we take the next question, one other point is, way in the beginning when I went to Europe, I would talk about monovision, and people were shocked how much monovision I did with LASIK and different procedures in the US. And I find that more adaptable because even in the case where the patient is looking for something more than the monovision, they can always put on a pair of spectacles to correct it the rest of the way. If they're doing their taxes or they're driving at night, they can adjust for it. But if you have a multifocal lens, you can't adjust for that. If there's something that's not perfect, you can't make it better.
Yes and no. Again, you know, for instance, now we have the chance to implant a piggyback multifocals in monofocal patients. And I can tell you, the patients with monofocal intraocular using glasses, they feel so happy once that you eliminate the glasses with a piggyback multifocal, like for instance the RT Plus. RT Plus is an artificial lens that is clearly an advantage. We need to read, and some of the EDOF lenses cannot offer that advantage. But this is debatable. This is why we are in a debate. Okay.
Quick comment.
Just a small tip of counseling diffractive IOLs, which I personally use, is I tell them, see, look, this how these lenses work is it splits the light, focuses at 3 points, and so on and so forth. And every time you see a bulb, you'll see rings around. That means the lens is working really well. I think once we say this before surgery, so the next day when they see those rings, they feel happy, oh, wow, my lens is working very well. But also I tell them that, look, don't worry about it. As the time goes, it'll start fading out. The most important point is we shouldn't keep thinking about it, and you should ignore it and do your routine work. So this small counseling tip really helps. Thank you so much.
Yeah, but you need to guide the patient, because patients don't understand what we are saying many times. There is a recent article in which the capability of the patients to understand what we say is estimated in 15%. So most of the patients are not understanding well our definitions about multifocality, etc., because they are not trained for that. But on the other hand, they want to be happy. So I think that we need to know how pre-select the patients, basically, in my opinion, about how to exclude those patients with ocular surface problems, patients that have not a good visual potential and negative personalities, as I told you. This is when the simulators can take a place. As David Chang is not here, David, are you there? No? I think that we can debate now about the simulator. And, you know, I know the simulators, I have used them as well. And my question to you and Elena is, do you really think that the patient with cataract can really decide which lens is better for him just with the simulator, because contrastivity is low, vision is not good, otherwise he has no cataract? I think this is good for refractive lens exchange, but even that, can you assure neural adaptation in 13 seconds? Imagine that you are in a driving simulator, and when you are learning to drive your car, and just in 30 seconds you have to decide which is your favorite car. It's impossible. You know? Yeah. So I think that this has a value indeed, but I think that outfront refractive lens exchange, and with many question marks, I think that neural adaptation takes time. It's not 30 seconds. It's indeed a great option, but I'm not sure. Elena, what do you think?
Thank you. I think that as the indication of cataract surgery has becoming more and more in a younger age, usually the cataracts aren't so dense. They cannot, prevent the patient when trying the simulator to have the idea of the differences of the kind of vision that the different IOLs can provide. So if we have a patient with a very dense cataract, probably the benefit of having simulation will be not so high, so to speak, as if we have some patient, for instance, with a 55-year-old years of age, or 60 or 65 years old of age, with his or her cataract, that still allows for some vision with not very quality vision, but may also benefit for trying the differences that the diverse IOLs can give. So probably, I think more and more in the future it will be a helpful kind of companion to have, and not to mention the idea of having this person to have the immersive experience of being, trying something that is anticipating what will be happening after surgery with the different lenses. And as more and more, as I was saying, the cataract indication for having surgery is becoming with a younger age. I think it will be more and more useful to have it at the office to provide the experience for the patient, besides the chair, the quality chair time, of course, and for the judgment of the doctor as well, and to become to be at the best shared decision, so to speak. But I think it will be, I'm a very strong believer of the technology.
Well, I would make one quick comment too, is like you said, younger and younger patients, if they have a severe cataract, then they're also going to potentially accept whatever you give them. Exactly. So maybe that's not going to be, it's the ones that are refractive lens exchanges that are really subtle cataracts that are going to be much more demanding in terms of what they receive. And I think it's always nice to have something ahead of time. It's like people are all focused on show me what it's like, and then they can adapt to that. And my final comment is, most of the time you don't want to do people with dry eyes or AMD or an epiretinal membrane, with some kind of multifocal, because it never works well. Maybe they don't have it now. What if they get it in a few years? Will their vision degrade, and they'll have to deal with it then? So there is always that trade-off of what can you give them that's going to last the longest and keep them the happiest.
Yeah, surely focus on the refractive aspect of cataract surgery. Yeah.
In the experience I have with the simulators, I think that they assist to you to detect those brains that are not good adapters. I call five-dimensional brains. So those that immediately reject a blurry image, they are not for multifocals. Those that are more or less the same with everything, good for multifocals. I think that you can more reject than select a patient positively. This is my experience, and I tried myself, and I was happy with everything. I was better with the multifocals, let me tell you, but I was more or less the same. Since that my brain was more easy to adapt. But I'm sure that if I am with anything that is not that good, for half an hour, we get trained. Train the computer. Our computer is very well trained. Yeah, Dr. Ang.
I like the way the simulator can simulate glare and halos or photic phenomena. But if I have it in my clinic, my main worry is I set an expectation that I may not meet with an uncorrected vision. For example, a residual refractive error. So if I had that, I would build in like a minus 0.75 or a cylinder to get them to a point where it's not perfect, but this is glare and halo. So setting the too much expectation is also a worry. If you put them on, they expect that after.
Mm-hmm. Yeah, of course, this is virtual
Okay.
reality. It's not the real reality, but it's something that will come in kind of an aid to speak for ourselves and to demonstrate so that the patient can experience by themselves.
Okay, I think we're going to resolve this question with our next speaker, Jorge Aleo, who's going to talk about accommodating IOLs as a future of lens-based presbyopia correction.
Thank you very much, Ron, and I am going to show to you what is, it's not my presentation.
Yep. You guys are off again. Number 7.
Dr. Alion.
This is the last talk.
Yes, this is the last. Ron, maybe that not to lose time, we can invert the program and you can follow.
This one?
Yes.
This one.
Is Dr. Sheetal Bra here? I don't think so. Okay, so she may not be coming.
Okay, so thank you, and now is the time for something new. This talk is going to be a bit longer because it's going to deal with concepts that are totally new for you. And I am the medical director of AIOS, so I am talking about the technology that we have been studying for now 18 years. First question is, can we restore accommodation, this complex mechanism that was described and probably is the only one true mechanism of accommodation by bone health so far away? Probably yes and no. And let me tell you why. In the past, we learned that we had many mistakes. I mean, many mistakes made us to decide and to choose some lenses because they were accommodating where they were not true, because the methodology for the studies about these lenses was poor, because there was a commercial bias, and the monitorization of the investigation was poor. Actually, the near vision tests were seen at 70 centimeters, which is not, as you know, the near vision testing on regular optometric basis. So the past tell us that we did mistakes, and this is a study that we published independently from the companies in which we demonstrated that these lenses were no different than a monofocal lens, as you can see here in this image, and only the crystallis for intermediate was a bit better because this lens had a 1+ near vision at the center, so it was similar to the AIOS that we have today. So we summarize everything that was so much disappointed about lenses in this paper that we published now almost 10 years ago, and this was a desperate moment in which accommodation was not easy to accomplish. Let me remember to you how we can change the power of the eye according to distance. We have only 3 approaches: either to change in axial position, angle with a single or dual optic, either to change in shape or curvature, or change in refractive index or power. Only these 3 mechanisms can change the power of the eye according to distance. And the second issue is how can we get the lens in the eye? Should be inside the bag or outside the bag? And let me explain to you why some of these lenses in the past fail. The capsular bag is a basal membrane of a lens epithelium, and one that is empty. There are no functions and no anatomical reasons to exist. Fibrosis and atrophy are going to follow, and the capsular bag theoretically cannot function in the long term when it is empty from its content. This was published by us in 2015, and we demonstrated in an experiment I'm going to show to you what happened. The experiment was in the old monkey, in which we implanted a measuring device either in the sulcus or inside the capsular bag when these monkeys were at the age of 9. 9 is when they are about 30 years of age, equivalent to a human being. And this is the measuring device, and we stimulated the ciliary body either pharmacologically with pilocarpine or by the direct stimulation of the ethical westphal nucleus. In any case, we could see that after 3 months, and especially after 5 months, there was no energy and no movement of this device when implanted in the bag, while even 2 years later, these forces were detected when the lens was implanted in the sulcus. So in this paper that is published in this reference, we saw in 2005 that the capsular bag was a wrong location for accommodative lens, and the forces generated at the sonular anterior capsule system are the ones that probably should be used for accommodation. Based on that, several models were designed, and finally the Lumina appeared. The Lumina is a dual optic lens in which 2 varifocal surfaces, one is sliding onto the other, creates a continuous change in the power of the eye according to distance. This is based on the Alvarez principle. Alvarez received the Nobel Prize in 1953, 72 years ago, and was the basis of all the autorefractometers that we have today. So this is the lens. The lens is implanted in the sulcus. the lens functions independently from the capsular bag, and the lens is working in the way that you would see in this animation. You see that the lens is moving in the frontal plane. This frontal plane is according to the forces transmitted to the haptics in the ciliary body, and this is the way in which these two varifocal lenses act as it happens in real accommodation, in which when the ciliary body is contracted, then the power is increased according to distance, and when it's released, the power is decreased according to distance. In other words, we have a monofocal focusing depending on the distance and not creating any multifocality. So this is the way in which the lens is implanted. As you see, the haptics are perfectly embracing the ciliary body, and the ciliary body, when it's contracted, pulls in the frontal plane one of the haptics onto the other, and and in this way, the lumina changes the power according to ciliary body action. So we had 3 studies: a phase 1 safety study that was performed in Alicante and in Fyodorov Institute, phase 2-3. Well performed in Bulgaria and in Alicante. I was sorted in all these stages, and I'm going to show to you the latest design, which is the phase 3 study that has just been accepted for publication in Journal of Refractive Surgery. This is the lens, how it is implanted, and as you will see, we always implant the 180 meridian. The 180 meridian is selected because the lens is measured with high efficient methods in order to be customized for this for this location. There is no toric model of the lumina so far, and the capsular size is independent from the result. This is the lens that should be implanted in the right position. If you implant it upside down, the lens doesn't work and creates the refractive imbalance. The lens is introduced in the injector. It's a regular injector that goes through 2.75 incision, and the injector can be used either monomanual or bimanual. It depends on what would you like to do. And the lens is, and this Medicel injector can be used as any other injector that you have in your practice. The lens, once that is inside the eye, has to be implanted, collapsing the anterior capsular bag onto the posterior. We use cohesive viscoelastic for the purpose, and then we open to 2.75 to 3. The tip of the injector is introduced in the anterior chamber, and the distal haptic is introduced in the sulcus with a movement that you have with the second hand. You push the trial haptic into the sulcus as well, and you verify that the lens is rightly implanted by the circularity of the capsular ring. This is the simple surgery that we need, and then the viscoelastic has to be removed. As you see here, these are the results. The results show that 81% of the patients had uncorrected visual acuity of more than 0.7 or more, and 100% was with best corrected for distance visual acuity when corrected in all cases. In uncorrected for distance visual acuity, we had 91% of the cases with the level of J1, and as you see, the best corrected for distance visual acuity in 100% of the cases was 0.8 or more. So this lens was working well for far and working well for near in phase 3 study. As you see, the patients in 88% of the cases could see even small characters with check invoices, and far vision was good, with good satisfaction preferred for the patient in watching TV. 100% of the patients raised vision, 7/10 in patient-reported outcomes analysis, and there is no change in the conservative function as expected from a monofocal lens, and there is no or minimal photophenomena as studied with the halometer of size. This is the demonstration that the lens accommodates. This is the graphic in which you see the change in power of the eye according to distance and demonstrates accommodation. As any physiological function that is recovered, you have a variability, and this variability reflects exactly what is accommodation. 75 of the eyes had a focus of 2.5 to 3 diopters at a visual acuity of 20/40 logMAR or better, and what means that we have some variability. The patients accomplish all of them good intermediate vision, some of them very good near vision, and most of them have intermediate to near vision accomplished with spectacle independence. This is very important and demonstrates that the eye has this variability in the defocus score. According to the study, we have a 12 and 24 months equivalent results. So there is no decay in time according to the diopter gain in near vision, and capsulotomy doesn't affect the outcome of the lens, but rather increases the accommodation as well. If you have a capsular bag disruption, bad news, you have the good news that the lens can be implanted in the sulcus. And look here, in this case, that we have 1.9 diopters of increase in power according to distance in this patient that had posterior capsular disruption. This is remarkable, and this lens can be used in those cases in which you have a problem in the operating room. We have analyzed and described a method to study retinal function with different intraocular lenses. These are retinal clinical function, and in this eye, you see that the accommodative lenses behave identical to a monofocal spherical as expected. This is important, and just to show to you the difference, this is a well-known EDOF lens that have not always so good quality retinal image. This is actually one of the worst, and this is the mini well, while the monofocal of Alcon S660 shows this image, while with the Lumina you see here that you have a swirl ratio that is slightly less than the monofocal, but is basically almost identical to the monofocal as well. So which are the pros and cons of this accommodative lens? I have to tell you that the accommodation that we gain is not exactly the one that we have in the defocus scope. This is why I call this lens accommodative plus, because we have some short accommodation as well that still have not been unveiled how it happens. The pros is that we have consistent near vision outcomes with excellent far vision, no division of light, and no aberrated, and with no conductivity loss. Long-term demonstrates tolerance to sulcus implantation. We are already with more than 10 years follow-up in the phase 1 study. There's a consistent phase 3 clinical investigation, has been published at the publication last month, and this is an absence of long-term, more than 14 years complications. On the contrary, we have a frequent PCO that due to poor opposition of the sulcus, so you should expect to perform JAGLIS in these patients before 6 months in at least 30% of them. And there's a disparity between the focus scope and accommodative gain. This is why I tell you this is an accommodative plus lens. Not all what we gain for near comes because change in power. And this is remarkable. We don't know. We have been unable to know why we have a extended depth of field effect with this lens. Some cases of iris pigmentary epithelium changes, but there is no pigmentary dispersion, probably because the surgery initially was more traumatic. So this is an ideal choice for irregular or highly aberrated corneas that are not selected for trifocal lenses, for instance, as we just mentioned. And you can read the outcomes of these studies in American Journal of Ophthalmology. Was the first paper, Journal of Refractive Surgery, second paper, and the third paper has been accepted for publication in Journal of Refractive Surgery in February 14th of this very year, 2025. You can read a full chapter about accommodative lenses, and especially the Lumina, in this third edition of our book that we will release in September 2025 with the name Multifocal Intraocular Lenses there and the practice. And we have one lesson in our online course with 500 hours of teaching activities online in English with multimedia offers about accommodative lenses, as well as in other intraocular lenses and corneal, cataract, and refractive surgery. And I thank you very much for your very kind attention.
Okay, thank you. Actually, if there's any quick questions, we may actually have a few minutes before we go on to the last two talks, but we can ask Robert to come on up and get set up. Obviously, this is kind of like the holy grail of presbyopia correction, is if we can actually get restoration of accommodation, that would be the way to go. And if we can do it with an IOL, then it takes care of cataract and everything in the future as well. I guess even with your experience, because you have looked at a lot of different models, what will it take to really come up with the ultimate accommodating IOL?
This is the lens, because the intracapsular lenses will not work. Believe me, will not work. And look at the different presentations in the past with different lenses. I'm not going to mention them that were implanted in the capsular bag. You cannot listen a single presentation in this meeting or the American meetings. They have disappeared because the outcomes were poor. This lens has been for 14 years investigated. We have an animal model, is working, and the only one problem is that we have to change the paradigm. So far, we were implanted lenses in the capsular bag. Now we have to implant this lens in the sulcus because the accommodative forces are in the ciliary body, not in the capsular bag. And so the resistance to the adoption of this lens will come because the change in the paradigm that we have in our computer about whether the lens is the crystalline lens back is the one in which the lens should be placed. It's not unaccredited lenses. Once that they are generalized, and obviously we need multicentrical studies to really verify everything that we have said. Science has to be repeatable. Once that this is repeatable, in my opinion, everybody will embrace this because we have no neuroadaptation, no dysphotopsia, no problems in selecting the patients. You can choose an aberrated cornea with good result, and finally, you can implant even in the absence of causal support.
Quick question out here.
I may have missed this, but I'm assuming there isn't a toric version in this lens, and if there was to be one, what are your thoughts about the stability of the lens in the sulcus for toric correction?
Yeah, the question is about toric lens. This has not been tried because so far we had some rotation of the lens. This lens is implanted in the sulcus. The sulcus, you know, that is not warranty circular at all, and this is why ICLs and phakic lenses rotate, and this is something that we know. With a new design and with a more rigid design, the rotation has been almost cancelled. This is why we're implanted only one meridian in order to really know what is happening, and the toric lens obviously will come in the future, but it's not available yet. Even that is under investigation. Thank you.
And sorry, just another quick question. Do you think there's variability in the patient's ciliary accommodation? And perhaps the next two talks will be a little bit more towards that, but that would certainly cause some variation in the near gain.
Yeah, you know, any physiological function is different from every one of us. Your biceps and mine are different, so we should expect variability when recovering a visual function such as accommodation. So I'm not surprised, and we were at the beginning surprised because we were expecting more or less what is happening in premium lenses. This is accommodation. Accommodation in a 40-year-old person is different to another 40-year-old person. This is not constant. There is a mean, but there's a standard deviation. And so you should expect variability. In my patients with Illumina, I tell them, listen, you will have excellent computer vision. Near vision will be good for most of the cases. You want to be sure that we have J1 or J2, I cannot promise that. It might be that you need glasses. It's more or less what you say with the advanced EDOF lenses. But this is better because EDOF lenses have halos and glare sometimes, and this lens has not.
Thank you.
Thank you.
Quick question.
What is the IOL formula that you prefer to implant this AIOS lens? And any corrections that you would make because the lens is not in the back but it is in the sulcus?
I don't know if I understood your question, doctor. Can you repeat it?
What is the IOL formula or the preferred IOL formula that you would use to implant these lenses, and any correction that you would make, because most of the IOL formulas are for the lenses which are implanted in the back, and now we are implanting in the sulcus. Are there any corrections that you have to do?
Yeah. You know, the IOL is calculated with a proprietary software, so it's not following any of the calculation formulas that are this moment available. You have, in order to guarantee the precision of the calculations, we use only the CASIA as OCT measurement of the different variables that we are involved in the calculation, and second, a proprietary software that is based on a CIMER simulation, you know, on a CIMAX simulation. And the precision is remarkable, you know, because about 82% were plus minus 0.5, which is really outstanding. So in our series, we didn't implant this lens in patients with more than 2 decades of astigmatism, and of course the standard deviation of the sphere equivalent is a bit more, but the sphere is calculated with a precision of about 0.25, and the industrial precision of the lens is 0.12. 0.12 means more than the average monofocal lenses, the industrial precision. Yep, doctor.
Leo, very wonderful talk. Just one short question about the complications. Did you meet any intraocular pressure rise, or in your population it's suitable for the Asian because of the shallow anterior chamber eyes, and maybe the anatomy of the sulcus maybe not suitable for this patient to implant the IOL?
Yeah, the sulcus implantation, we use sulcus implantation for phakic lenses, we use for piggyback, and nothing happens, you know. So why it should happen in this lens? Because it is more bulky, true. So we have been following these cases for any pigmentary dispersion out from the first month. There is pigmentary dispersion the first month. Second, because chronic intraocular inflammation or CMA, macular edema, and number 3, because increasing pressure. Neither of the 3 have been happening in the 14 years follow-up from the phase 1 study. So pigment dispersion, pigmentary glaucoma, any chronic inflammation have not been detected in these long-term studies, and the incidence of CMA detected by us has been at this moment 1.2%. So we have all these variables studied and have not been influenced. It's not surprising because just think how many cases with the ICL develop glaucoma, pigmentary dispersion, or chronic inflammation. And we're implanting these lenses every day. Thank you.
Okay, we're going to go ahead and move on. So the next 2 talks will round out the session, and there are kind of more emerging concepts that will be discussed. I'll be giving the second talk. Robert Ang will give the first one. And this is really looking at how do we potentially restore accommodation without putting an IOL in by working on the sclera.
Good morning, and thank you for having me. We're now going into non-cataract patients, so presbyopic patients who search for a solution. So we started from cornea, lens, sulcus, and now we're trying something on another part of the eye, which is the sclera. So I'm a consultant and investigator for ACE Vision, which is one of the developers for this technology. So as a background, presbyopia, when we're talking about it, starts at age 40, and going back to physiology, it's rooted to advanced glycation end products, wherein our sun exposure causes cross-linking effects in different parts of our body, including our eyes. And one of the most exposed areas of the eye is the sclera. So as you grow older, more cross-linking, more stiffening of the sclera, so it prevents the accommodation reflex or slows it down. So that's the theory behind this therapeutic advances. So as you can see, when you're young, your lens is very flexible. Your lens is attached to the ciliary muscle. It's attached via the zonules, and the ciliary muscle is attached to the sclera. So we can't touch the ciliary muscle, we can't touch the zonules. So can we modify the sclera somehow to help with accommodation and improve dynamic range of focus? So decreasing ocular rigidity is one of the theories behind resolving presbyopia. So we want near focus to improve. We want it physiological, which is arm's length, but we don't want far vision to change. So how do we do it? So in this laser scleral microporation, we cover the cornea with a shield so that we don't fire anything on the cornea. An erbium YAG laser fires multiple shots, creating pores, partial thickness in the sclera in 4 quadrants. So the goal is to rejuvenate the whole complex of sclera, ciliary bodies, zonules, and lens so that it continues to function or rejuvenates the function again. So we did a study. We started about 3 years ago on 50 patients. So this is purely on emmetropic presbyopes. It does not include correction of refractive error. We recruited patients with a mean age of 52 years old, and they had to have reading glasses of at least 1.5 diopters, but no distance correction. So they had to be happy with far. So this is the procedure. So we have this handheld. So this is the Generation 1 laser. It's a handheld laser that fires these YAG shots in the sclera in 4 quadrants in a diamond grid pattern. So 4 quadrants will get treated with this 75 to 80% depth pores in the 4 quadrants to relax the sclera and hopefully promote movement again with the ciliary body and the zonules. So the goal is to provide a minimally invasive treatment. Second is do not touch the visual axis. So we don't touch the cornea, we don't touch the lens. And we are in the next stages of doing studies if we can repeat it or augment it in the future. So at day 1, most patients feel that their near vision has improved, some more than others. You see the pores, the the conjunctiva has healed because it's transconjunctival treatment. So first few days, they will feel a scratchy movement. The best thing about it is the most common adverse event is a subconjunctival hemorrhage. There's no other adverse event or complication we encountered, and we just treat them like any conjunctival abrasion or corneal abrasion. So one thing we check is, are we inducing any corneal or refractive change? So these are checks in terms of cylinder change. Are we inducing any type of coma effect or astigmatism effect over 24 months? And you see the plots that the cylinder is still within the middle, so we're not cheating by inducing any refractive change. So sphere itself has maintained. Of course, over 12 months, the patient continues to age, right? We cannot stop aging, but we monitor the sphere and the cylinder and the MRSE of the patients over time. And as you can see in the graphs, both uncorrected and distance corrected, the green line represents distance vision. They're mostly flat because they still see well for distance uncorrected. Intermediate vision has improved a lot. So the blue line is intermediate vision, and the near vision also improved. But mostly it's a very big intermediate vision gain over 12 months. But over time, they age 2 years. So this is a 24-month plot, no, of patients. Reading glasses are less. It is not a J1 procedure. We were not able to achieve J1 in these 50-plus-year-old patients, but about J3, J2, J3, reading glasses are less to none, and they have a significant reduction in reading ability. Subjectively, they have less stress in terms of the fatigue in reading. So we also had quality of life questionnaires, and we see a very big improvement in intermediate vision for the patients, computer, cell phone, and all that. Near work, of course, sometimes is still a challenge for these patients, but there was improvement. So in conclusion, our study showed that the first phase of our study was safety. Are we causing any adverse event? Second is, are we causing what kind of effect? We have good intermediate and a modest amount of near vision. It reduced their dependence on reading glasses. The most important feature is we reserve the cornea and the lens for future use, and it improves their quality of life. So this is laser scleral microporation using an erbium YAG laser on emmetropic presbyopes. Thank you.
Thank you, Dr. Ang. And we're going to have a joint discussion because the next paper is by Dr. Kruger about novel emerging technology in scleral-based accommodation restoration. That means exactly the same topic, but with a different device. Thank you.
Okay, thank you, Dr. Alio. Just we can get my slides up here. Okay, thank you. It's the same title as Dr. Ang, but again, it's a little bit different concept and principle in the same tissue, the sclera. So just disclosure, I am a consultant with Alcon, and I'm currently an unpaid medical advisor for Senogen, which is a company that's working on this with novel energy sources, and there's no commercial product as of yet. So the potential for presbyopia market is huge. This is probably the largest refractive market that's really out there that can be tackled with those who actually have the resources to pay for it. About 26% of the world's population is presbyopic, which is over 2 billion people worldwide. With all that, there's really no great way of restoring accommodation, which I believe is the holy grail for presbyopia correction. I think a very important point is lack of accommodation or presbyopia is not entirely due to a hardening lens, but also due to a stiffening sclera. So as a background, holmium laser LTK was done at the beginning of the millennium for corneal reshaping of hyperopia. And for the most part, it worked, but ultimately failed because there was regression of effect But from that was some understanding to say, could we target this in other structures? And but going back to 2008, this is John Kanellopoulos, who treated using an LTK laser on the sclera to see that a patient could not change their distance vision, but actually get some improved reading. From that, there was an investigational feasibility trial that was done in 2013 in the Netherlands, and 100 patients were enrolled, they were followed, and their intraocular pressure and ability to read up close were tested over the course of about a year. And you can see that there was some pretty good improvement in near vision with no change in distance and some reduction of IOP during that same time. So the concepts of LTK were to shrink and soften tissues, whether cornea or sclera, but not to denature it. And to really achieve the shrinkage and the softening effect or increased compliance, you have to keep the temperature range somewhere between 60 to 70 degrees. Once you go up to about 80 or more, you're going to see more denaturation, which is going to lead to wound healing, regression of effect, and that's a lot of what was seen with LTK in the cornea. And so with that, we've been studying different wavelengths in the infrared range, and the 1.55 micron wavelength is really optimal in terms of safety and absorption, and it helps to keep the temperatures in a more controllable manner because it's a very short pulse where the pressure doesn't build up, or the temperature doesn't build up. It also happens to be the wavelength of LiDAR, which is being used for autonomous vehicles. It's in the communities in a large way, and is otherwise very retina safe. So again, the limitations with holmium is in order to get deep penetration, you're going to have to do excessive raise of temperatures, and you're going to get thermal denaturation. And when we did an actual calculation of penetration depth, looking at scatter efficiency and absorption coefficients with different lasers, we found that the pulse diode at 1.55 was going to give more than twice the depth with less real excessive rise of temperature because of the short pulse width. This is all important because we want to be able to get increased compliance of the sclera, or more flexibility of this aging sclera. And the reason for that is the posterior vitreous zonule has been nicely demonstrated by Marion Croft to limit the movement of the ciliary body in an aging rhesus monkey, as it does in humans as well. And so if we can increase the scleral compliance, that zonule will move once again like it does in a young individual, and give us that flexibility of movement of the ciliary body without kind of holding it back. So the concept of laser scleral therapy, or laser scleral ciliary translocation, is to try to restore those mechanisms of accommodation by treating a little more energy anteriorly, a little bit less energy posteriorly, which is distributed nicely by a diffraction optical device. And it allows the shrinkage more anteriorly to translocate the ciliary body outward and backward, and yet the posterior sclera can be then softened to allow the compliance and movement of that posterior vitreous zonule. This is how it's done with a diffractive optical element where the light can be split out. There's a precorneal interface which protects the cornea and allows the light to distribute, being a little bit more intense anteriorly than posteriorly. For preclinical testing with this wavelength, we've looked at a number of porcine eyes, looking at OCT, OCE or elastography, and also histology with triangulation to see what kind of relationship of the change of shape inside the eye. So with OCT, we can nicely see that treating a therapeutic range, we can open the actual iris ciliary complex by about 4 degrees on average with a treatment that's just posterior to the limbus. With histology, by looking at triangulation of the limbus to scleral spur before and after, we can increase the overall triangulation, which means that that ciliary body is rotating a little bit outward and backward. And that helps to give a little bit more force of contraction at the ciliary body during accommodation. And then finally, with OCE, looking a little bit more at the posterior sclera, we can see that, that the treatment actually reduces the scleral stiffness up to 3 times in the overall flexibility. And we can nicely see some of that shape change in this OCE where the color representation increases and increased scleral compliance. This is how it's being proposed for clinical delivery. It's a simple handheld device that can be mounted onto any existing slit lamp. It's low cost, battery operated, so it's very efficient and inexpensive, and protects the surface, and you can do quick treatments transconjunctivally. It works right through the normal optics of the slit lamp, so you can see what you're doing while you're operating, and there is even a small camera that's located onto the device that will allow visualization during the surgery for those next to the surgeon. Our next steps in the concept would be to do more human biomechanical studies with cadaver eyes, and also some pilot clinical testing where we can kind of refine those optical parameters to optimize, you know, even with using thermal temperature devices to make sure we're in the right range. And then some clinical trials for both safety and efficacy. In fact, we've actually treated now 11 subjects in Slovakia, and you can see that during this time you really see no change on the surface because it's a very low heating effect. But there's good fixation, negligible visual hyperemia, and minimal discomfort. Sometimes patients feel a little bit of stinging, but it's very tolerable for those patients who were treated. In fact, these 11 patients were volunteers. They were all aged from 44 to 63 years of age. And prior to surgery, they were all 20/20 uncorrected emmetropes ranging from -0.5 to +0.75. And after the surgery, their distance vision was unchanged, but they improved by anywhere from 1 to 5 lines. And this is, again, just an early prototype treatment to see what kind of effects we could get without perfecting all the energy delivery to see that it was safe. And we saw that there were no complications with it. In fact, our best outcome in a 44-year-old who was 20/60 near was that they received 5 lines improvement to 20/20. Very happy with the comfort and the visual outcome, and it was a simple treatment that just took 1 minute to apply the laser energy to the sclera. So in conclusion, laser scleral therapy is a promising, minimally invasive, and even repeatable method for restoring accommodation that's still going to need further testing. Using a portable, low-cost laser attachment to a slit lamp would make it easy access to a global population with needs in presbyopia. Our pilot clinical efficacy and safety has demonstrated some positive outcome to pursue further, and so formalized clinical trials are planned within the coming year. And we'll make the sclera great again. Thank you.
Thank you, Ron, and we can make a discussion about both techniques, and as both it is about the sclera, the debilitate the sclera at the area of the ciliary body, and we'll make the first question to both of you, right? So as far as we have the ciliary body with anatomical variability, how do you know that you are treating just the sclera that you need and not in another place? The ciliary body is not circular and has not the same distance from the limbus in every quadrant.
Yeah, I think one interesting point about this is there's a broad area of treatment. I think even with the LSM procedure, it's not like we're targeting one area that's a millimeter and it has to be in a precise location. You're targeting an area that's fairly broad, and so even with a small anatomic variation, if you're making tissues more compliant and the shrinkage may alter a little bit the orientation, it doesn't take much to get back accommodation that you lost. And I firmly believe that we probably see stiffening in our sclera well before we see stiffening in our lens to the point that it really limits our accommodation. I think we're always thinking the lens is the reason why we can't focus anymore. It's gotten too big, it's inflexible. I actually think that the sclera happens first before the lens becomes limiting. And I think this trajectory of research may take us to places where we can offer younger presbyopes a solution.
Yeah. It's the Saccard theory, right? Saccard theory of accommodation. And one more question, and now Dr. Ang will go. Which is the mean and standard deviation of the gain that you have in terms of diopters? The patient has 1.5, 2 diopters gain of near vision.
I actually direct that to Dr. Ang because his product and research has a lot more data that's been established for several years. Ours is still kind of new, and so I don't have as much of the robustness to answer that yet.
So what we've realized is if we convert it to reading ad gain, it's about 1 to 125 diopters with a plus minus 0.5. So max is about 1.5 diopters for now. And to answer the question of the zone, so there were studies on simulations of retina and scleral movements, and there were 5 zones identified. The closest zone is near the limbus and moving all the way posterior. That's why the shape of the treatment is diamond, where the most closest to the limbus gets less treatment, while most of the treatment is about 2 to 3 millimeters back, where most of the stiffness and most of the relaxation of that ring of tissue will occur to provide more movement. So so far, we have 1 to 125 diopters of gain in reading ad. That's why our study targeted only 48 to 55-year-olds. So our study was only that, not the young, not the too old, with a mean of 52, because we wanted to see if those people now, emmetropes, definitely at that age need reading glasses. So 48 to 55.
Yeah. According to the anatomy and the knowledge we have in glaucoma, the sclera heals, sclera heals. Sclera can replace the collagen quickly. This is why we use mitomycin C. We know that even with mitomycin, sometimes we don't have filtering blood, etc. So how can you guarantee, if you can at all, the stability of the refraction that you gain with this method?
Actually, there's part of the research is watching them. Now we're close to 1.5 to 2 years out on our 50 patients, and we see that some of them do heal. So there are 2 things that happen. Number 1 is the sclera heals. You still see pores, but of course new tissue will form inside those holes or pores. Second is presbyopia progresses. So because of that, we saw like some of the patients, they lose 1 or 2 lines of near vision over 2 years. So of course, even patients and us, the main question is, what now? Can we treat more by expanding the zone? So the next treatment is, can we retreat them over time? So,
okay, what about your laser?
Yeah, real quick to Robert. If you did retreat, would you just go adjacent to a virgin area, or would you go back to the same area?
the new generation 2 laser will be an OCT guided treatment, which can either target the same pores or add shots around the periphery. So this one cannot be guided, but the OCT guided new one will be able to. So there are 2 strategies. One is pour again in the same hole, and one is expand.
What are your thoughts about the mechanism of why it works where you're treating?
I think it does soften, makes that area mushy in 4 quadrants equally. So it's like loosening your rubber band kind of effect.
Yeah.
But then I think it heals again. So we have to answer that over time.
Yeah, and at least with LTK, we found that, you might get some effect, but if there's scarring that occurs, the effect might be lost. And so that's why we've been looking more at the idea of, can we heat it without scarring, loosen up the collagen. It's basically like disaggregating cross-links that naturally happen with age. And we're hoping that it can be repeatable as well. What was your question?
Yeah, one question, just I'm guessing, we have the mice with a very elastic sclera. This is why they are mice, because these patients become presbyopia as well.
Yes.
So with thin scleras, elastic and weak, presbyopia appears. So could we involve another mechanism in your technique? Because if this theory is true, myos could not be presbyope.
I think the main thing is depth. I think the secret sauce is what depth and what extent. That's why we check OCT and UBM to check depth, but maybe refining the depth percentage based on the original thickness of the sclera in the area. So it's a
Very
depth
good.
percentage.
Anyway, congratulations, because I think that you are exploring, Ron and you, Robert, the new area that has been not that new, because we have had scleral techniques for about 25 years, but still not successful. But many techniques are not successful until some great technique or good idea comes into the practice. So I think that we can close the session. Ron, I think that we had a very stimulating session. We went from intraocular lenses, premium, let's go, all types, EDOF, trifocals, and accommodative, which is the new baby. We went through the mechanisms of accommodation as modified by scleral surgery, and I think that we have now more options than before we had for the presbyopia, and these many millions of patients, presbyopes, will have, in my opinion, I hope, in the immediate future. What do you think about that?
Yeah, I think, like I said, it's the holy grail of refractive surgery is coming up with a way to actually restore accommodation. I think that's really the thing to drive toward. And I think with time and innovation and technology and a lot of bright people behind it, we'll see some major strides in the future. So I think we're just scratching the surface on where we're going to continue to go with refractive surgery.
Well, thank you very much, Ron, and I want to thank, on behalf of Ron and myself, all the speakers for the very nice talks, and especially to be in time and to be able to allow discussion. Thank you very much, and the session is closed. Very good.